The the So we have got, this is our last weekend of pharmacology. I know you guys. This has been a volume loaded course for you guys, and you guys have done really well going through this. This is one of the more difficult courses, mainly because of the volume of material that's covered. We've got a lot to cover this weekend. It's the end of the semester. And what I'm going to tell you is there are some slides as we go through that if I, emphasize to you, I'm trying to, give you some because of the volume material we're going to cover, I'm going to try to give you some hints, especially of some areas that, for you to study, because there are a lot of slides that we have here. There's a couple of drugs a few of the classes of drugs you will be aware of. I think most people are aware of, so those may be a little easier. And we're going to try to do everything we can. I'm going to make an announcement about, I don't know if you guys have seen it, but have any of y'all seen the announcement about the FDA's increased warning with regard to zolpidem and Lunesta? Just curious whether that came through your email or whatever, but basically what's happening is they are putting a black box warning on zolpidem and Lunesta, particularly about the sleep driving and the sleep activities. So that's something you might want to take a look at. And if you're on MedWatch, you should have gotten that announcement. So again, if you haven't signed up for MedWatch, I really encourage you to do so, because I think there is a lot of the information that will come up that'll keep you current and help you in your practice. Okay. All right. So today we're going to start off with really the analgesics or the pain relievers. And it is a big thing there. Monica, I will just tell you, I know several people, my wife takes it, and I know people that have been on it for years. And we have seen every now and then that even though they've been on it and everything seems to be stable, we've seen some instances where that they start sleepwalking or sleep eating or whatever. I mean, my joke about my wife is she sleep eats, and one of the things that happens is basically that she'll get up. She was saying a couple of years ago, she said that this Ambien is making me gain weight. And I was like, well, the reason you're gaining weight is because you're getting up at night and eating. The first time we discovered she did it, she put away like a huge bowl of banana pudding. We got up the next morning, we knew she had made some the night before, and we figured there should be at least like 3/4 of it left, and she had eaten the whole thing during the night. But this can happen. I will tell you that what they've tried to do is, especially in women, they've suggested cut the dose in half. That's been a strong recommendation that for males it is recommended. But we do have a lot of people that have been on it for a long time and will not take it off. I mean, part of the issue is it's almost a placebo effect that if they're afraid that if they don't use it, then they're not going to be able to go to sleep. So they get anxious about it. So that's part of the issue that comes into play. I will tell you that I don't know if it's in I don't think it's in the new warning, but or the black box warning, but I will tell you that if people are combining alcohol with it. So for example, someone has maybe a nightcap before they go to bed and puts it in, is more likely to occur. We also see that even we've had some people that have had dinner, and had a glass of wine with dinner and then taken the Zim within an hour and a half to 2 hours, and we've seen evidence of that. So, but what you said, Monica, they don't see the risk. Everybody's taking it. It's been around for a long time. And of course, they don't anticipate that they're going to, they haven't sleep drove or sleep aid or whatever. We do see people that sometimes get online and make purchases and send texts and things like that, which people don't really attribute to it, but that has occurred. So just as a heads up there on that, we will actually talk about these drugs for when we talk about the advanced anxiety, because I will teach that part. And I will talk about the sleep drugs. That's included in the anxiety, so we'll go into a lot more detail about that. Okay. Okay. So today we're going to start off with this morning. We're going to try to cover this morning and somewhat of this afternoon. We are going to cover really the analgesics, the pain relieving drugs, and the antipyretics. the fever-reducing drugs. Many of these are over the counter. Some of these you need to be aware of from a standpoint of many of your patients will be taking them over the counter, and some of them can have some side effects that you're aware of. A little bit later on, whether we get to it this morning or right after lunch, we'll be talking about the opioids. I'll give you some information with regard to things that are being discussed now about the opioids that I don't have in my slides, but you might find as useful information. Okay. And then we're going to finish up the weekend. The worst ones that you'll probably struggle through the most is the antibiotics, which we will cover last. And I'll work with you on those as to what specifically. I'm not expecting you to be prescribing antibiotics, but you're going to have a lot of patients on the antibiotics. And so there's a few things that you need to be aware of in particular about certain antibiotics. A lot of them deal with potentially drug interactions with centrally acting drugs. And so there's a lot of slides there. Some of those are there, as I've told you before. Some slides, which I don't have marked in red, are really for context to sort of help people understand them. And but what I'm going to test you on will be in the red. So and we'll also talk about some of the treatment of some of the movement disorders, Parkinsonism, and things like that. Okay. So a lot to cover this week, and we're going to try to help you as much as I can to reduce your anxiety if that's at all possible. Okay. So let's start off with just sort of a review. Is many of the analgesics we're using, one of the main reasons people go to the doctor, and the number one reason, in fact, is pain. Okay. And what we found is that there are a lot of diseases. We've talked about several in clin medicine. We've also talked about several as we've gone through some of the therapies this semester. But so anyway, what we find is a lot of diseases have a component of chronic inflammation. Okay. So what happens with chronic inflammation is basically your body is reacting to something. For example, it can be a simple thing. An acute inflammation is you cut your hand, you get a splinter in your finger. What happens is that, it gets red, it gets painful, it swells up. It's all inflammation. That's what occurs. It's your body's defense mechanism to, let's say you just do something like a paper cut. The thing about it is that with a paper cut, pretty much what's going to happen is the body is reacting primarily to potentially introduction of bacteria. Okay. So when you think about it, is that the way I think about it with regard to the inflammation is it's like the body is throwing a hand grenade down there. It's sending a lot of stuff, and there's some collateral damage, if you will. I have a small cut on my hand. The other night in martial arts, we were doing knife defense, and although we're using plastic knives, I got stabbed. And so what I saw around it, it was painful. After, the next day, it's red around it. There's a scab forming and so forth. But all of this stuff that we're talking about was the body's reaction to the fact that the skin had been broken. Okay. So what we see is an acute inflammation. We see that the body reacts by sending white blood cells. We see histamine being released. I think we went through some of this aspects of inflammation earlier on in clin medicine and maybe touched on it with the antihistamines. Well, with chronic inflammation, what's happening is that whatever is inducing inflammation is still the stimulus that causes the body to react. So what you find is it's a chronic inflammatory condition. And what's going to happen is that the damage, whatever initiated it, is going to cause cell damage. Well, when the white blood cells, and in this slide I've got leukocytes, when the leukocytes move in to sort of, what the leukocytes are going to do is they're going to come in and they're going to act, basically try to attack the bacteria. They're going to attack damaged cells. They're basically coming in and policing up, and everything. And so what happens is the way the leukocytes destroy these cells and destroy debris is basically they release enzymes. They're lysosomal enzymes. And these lysosomal enzymes are pretty powerful, and they sort of digest the whatever, it's the bacteria or the damaged cell or whatever. So the problem is that the leukocytes come in and they release these lysozymes. But the problem is those lysosomal enzymes are not specific targets. It's, basically you're releasing the enzyme, and the enzyme's going to hit the damaged tissue and the bacteria, but it's going to hit some of the good tissue. Okay. Now, another thing we see, and the reason I have these in reds is because this is the basis for some of the drugs we're going to use in inflammation. What we do know that during this inflammatory condition, that we have a lot of substances like cytokines and thromboxanes and leukotrienes and prostaglandins. These and eicosanoids, which are another term for like prostaglandins and related substances. So they are formed from arachidonic acid. Where does the arachidonic acid come from? Is a lot of our cells, cell membranes have they have phospholipases there. Phospholipids, and phospholipases can break down arachidonic acid or break down the lipids and form and release arachidonic acid. So when arachidonic acid is released, the arachidonic acid can then be used to form eicosanoids and prostaglandins. Okay, so we have this entire eicosanoid prostaglandin battery going on, which is mediating and maintaining the inflammation. So one of the things is that when we target these inflammatory conditions, one of the things that we're doing is we're basically trying to reduce the prostaglandins and the eicosanoids, because although they're helpful initially, that when they stay around, they're damaging the tissue. Now, the other thing we have is that when these cells basically release the lysosomal enzymes, another thing that's formed, sorry about that, another thing that's formed is free radicals, such as hydrogen peroxide, hydroxyl, even superoxide. And these free radicals that are formed, remember, free radicals don't stay around for a long time. They basically are released and they react very quickly with whatever is next to them. So what we find is these free radicals also can damage tissue. So what we're going to look at is a lot of these analgesic agents that we're using, or anti-inflammatory agents would be a better term. A lot of these are designed to interfere with the inflammation process. Now, one of the drugs that we see used a lot was steroids, corticosteroids. But one of the problems with corticosteroids is that long-term use created a lot of problems. Okay, we talked about this when we talked about the pulmonary drugs. When a lot of people had pulmonary things, we used to use glucocorticoid and corticosteroids quite frequently. We've reduced, and we would give it systemically. Now we've reduced using it, and what we do is we use it locally through an inhaler. So the reason I have this slide here is that chronic inflammation, which is one of the main reasons why individuals take these analgesic drugs, some of these substances are basically at the center of this, and the idea is that if we can interfere with those, then that helps us quite a bit. So really the issue becomes that why does the patient show up? Is mainly because pain. During these chronic inflammation situations, patient usually starts developing pain. Let's take a look at a couple of them. So one of the things is that they come in. I was fighting this last week, and a couple of weeks ago, I sort of twisted my knee a little bit, so it's been inflamed. And so, one of the things is that it's swollen. I know what's created a problem is that I've had a torn MCL in the past. There was already arthritis set up, so I know what my knee pain here is. The twisting probably did it, but it's an arthritic condition that is basically creating pain. So what happens is that it is painful when I walk or when I stay on it. It gets, we've all gone through it. If you sprained an ankle, twisted your wrist or something like that, these are inflammation, and typically refer to these as sort of acute to subacute or subchronic, because they last a few weeks and then pretty much go away. But what happens is that, my knee may swell and it feels a little weird, but what would really drive me to the doctor is if the pain doesn't persist, if it keeps persisting. And so one of the things is that the idea is that why is the pain occurring? it is due to an inflammatory condition, okay? The inflammation and these mediators of inflammation, basically what they're doing is they are stimulating the nerves with regard to around, for example, in my knee, which causes it to, the inflammation is causing the swelling. So I've got a couple of things happening. The swelling may actually be pushing on the nerves, creating a problem. And secondly, the other thing that is occurring is that the substances released as a result of the inflammation are probably acting on the nerves, okay? So the other thing is that we do know that with chronic inflammation, that inflammatory response in responding to whatever the initiating issue is going to produce some tissue damage. That tissue damage is going to be due to this inflammation that's hitting surrounding tissue. So from a therapeutic strategy, the first thing that we're hoping to do is to reduce or eliminate the pain. And secondly is by decreasing inflammation, we should either reduce, or if we're fortunate, we may actually inhibit some further tissue damage, okay? Because one of the things that happens with like arthritis is that over a period of time, what's going to happen is that you get inflammation, which damages tissue, which creates more inflammation, which damages more tissue. And so what's happening is the presence of the literal presence of the chronic inflammation is what is going to create additional tissue damage. And so you take somebody with arthritis, and basically over a period of time is between the chronic inflammation wears down, for example, parts of the joint to the point where we're down to rubbing bone against bone. And then not only rubbing bone against bone, but the other thing that's happening is basically the inflammation may be damaging that bone, which makes the bone rough, which makes it, even more so. So what we find is that if we can reduce the inflammation, that often results in relief of pain. And also it typically reduces or inhibits the tissue damage. So that's sort of our therapeutic strategies that we're going to look at. Now, we're going to talk about a group of drugs that's very common, and we have a couple of them over the counter, but we've got several drugs that fall into the category of NSAIDs, NSAIDs, okay? These NSAIDs, basically that stands for non-steroidal anti-inflammatory drugs, okay? So these drugs were designed to replace the steroids, okay? The name became even accepted, non-steroidal, because of that, okay? Now, some of these, their main mechanism of action, which we'll go into in just a moment, is that they are going to inhibit an enzyme called cyclooxygenase, okay? We refer to that as COX, okay? COX stands for cyclooxygenase. And we've got several different classes, and I am not going to ask you, for example, is this an acetic acid? Is it a phenamate? Is this a naphthylalkanone, or is it whatever, salicylate or whatever? No, I don't care that you know that, okay? If you're a chemist, if you were, a lot of the med schools like for people like their students to know this, but from your standpoints, it's not anything that you need to fill your brains up with, okay? Now, we had the non-selective, and that we've discovered there's two cyclooxygenase forms. So there's cyclooxygenase 1 and cyclooxygenase 2. The non-selective ones inhibited both. But a few years ago, we had a big announcement. This was back in 2003, before 2005, let's put it this way. So we had suddenly an introduction of a new class of NSAIDs called selective COX-2 inhibitors. The idea here was that certain drugs could be administered at dosages where their main action was on cyclooxygenase 2. And they had very little, if any, effects on cyclooxygenase 1. Well, the advantage of that was that one of the major side effects of NSAIDs is gastric bleeds. And so it was believed, and I'm going to go into this in a minute, a little bit more detail. It was initially believed that the COX-2 was the cyclooxygenase that was expressed where inflammation was. And the cyclooxygenase 1, COX-1, was expressed in other tissues, like the gastric mucosa. So the idea was by only inhibiting the cyclooxygenase in the inflammatory state, then we would not interfere with cyclooxygenase 1 and we wouldn't get the gastric irritation. So it would reduce bleed. So we had actually 3 drugs that were released, celecoxib, rofecoxib. The other one, I can't remember exactly. I can't remember the name, but it was Bextra. So we had basically Celebrex, Vioxx, and Bextra. Well, in around 2005, and these hit with a storm and they were prescribed like crazy. Well, a couple of things have happened. Number one is that around 2004, 2005, I think it was 2005, the FDA came out and said there's problems. Bextra was pulled off the market because of one, serious skin reactions like SJS and 10. And Vioxx, most of you are familiar with, was pulled off the market because it would seem to be increasing the risk for heart attacks. So it left really only one, which was celecoxib, which is still on the market. But people got nervous. A lot of the docs that were prescribing hated for it to happen because a lot of their patients were doing real well, but the risk for these other things were a real problem. So now most of the drugs, other than celecoxib, all of the other drugs are considered non-selective, so they hit cyclooxygenase 1 and cyclooxygenase 2. So as I said, there's several chemical classes. We see this, if you look at the structures, and again, the classes that I showed you a minute ago really evolve around differences in structure, okay? And what we find is that this chemical diversity of structure produced a fairly wide range of pharmacokinetic characteristics, okay? And we also saw a few differences in side effects. The NSAIDs were, people liked them when they started coming out because one, they're absorbed orally. So for example, you don't have to go get it. Think about it. I don't know if any of you that have had, arthritis or had some problems or something like that. Has any of y'all had or know someone that goes in on a regular basis to have steroid injection into the joint? And if you know of someone that does it, what is the number one complaint with regard to that? Okay, probably the number one complaint is going to be that it hurts. Okay, I had some surgery done on one of my fingers, my hand, 3 or 4 years ago, and I also had some one of the joints in my finger was inflamed, not enough to do surgery, but they were going to do corticosteroids. And I talked to them, man, while you're doing surgery on my wrist, go ahead. And so while I was asleep, they gave me the corticosteroid into my finger. But number one is that many people complain. I mean, right now with my knee, I know if I go back to the doctor that the recommendation is going to be to inject a steroid into my knee. And my thought is, as of right now, is no, because I don't want the pain that's dealt with it. Yes, I can be called a sissy because of that, but that's fine. I'm old enough to not really bother me. Okay, but the other thing that people say is that, okay, it hurts, and not only does it hurt, but it doesn't last long enough, okay? And in fact, some of the orthopedists will tell you, like I had an orthopedist that did a lot of injections in people's elbow, and he said, in reality, probably only about 10% does it really make a difference, but it makes such a difference. They tell everybody, so more people think that it does. And he said, it's when it does work, it works pretty well, but again, it wears off. And I don't know if you've seen it now. There's this new technique that everybody's been advertising. It's for knees now. It's called Cool something, which basically it is a nerve ablation. What they do is they actually go in, and by radio frequency, what they're going to do is they basically ablate the nerve, so that takes away the pain. So, and that they're saying is clinical trials are saying that this lasts for about a year. But that's the new hot thing now, is to come in, and it's like, if you're not quite ready for knee surgery, let us do this cool, whatever it's called, but it basically it's an outpatient procedure, and pretty much you can go about your activity the next day, and even late that day. But apparently it's a radio frequency. I don't know if they make a small incision and insert the probe close to the nerve, or if they go through the skin or whatever, but basically it's a nerve ablation. It's not taking care of any of the inflammation. What it's going to do is it basically removes the pain. That's what's at there. So we have a lot of categories of NSAIDs, okay? Now, most of them actually are metabolized pretty well, usually through cytochrome P3A. Some go through 2C. A lot of them are highly protein bound, so that's sort of generically characteristic. The way that all of these drugs work, okay, pretty much is that wherever, so for example, I've actually had patients that have asked this question, or my students have had patients ask them, that when they take, for example, ibuprofen, how does the drug know to go down to where your knee is hurting? And that's been a legitimate patient question that we've had forever. And what the patient's not understanding is only their knee hurts. They don't understand that the NSAID is distributing throughout their body, and it's just the fact is that it distributes to the knee that hurts as well as the rest part of the body. And so as a result, yes, we get pain relief and decreased inflammation, but we also have the potential consequences of the actions of the drug at other tissues, which is typically the side effect. So the way that these drugs work is pretty much through this mechanism. Is basically what they're going to do. I'm trying to get a color here. Okay, so they're going to inhibit the rate-limiting enzyme, which is the cyclooxygenase, which we refer to as COX, of prostaglandins. So by doing that, they decrease the production of prostaglandins. And the idea here is that by decreasing prostaglandins and other related substances, that basically, get back to the first slide I showed you, that basically is reducing the inflammation, okay? And as I said before, COX-1, that's present almost in all tissues. COX-2 actually gets induced. So when you get inflammation, what happens is COX-2 starts being induced, so its levels start increasing. It starts generating, when the COX-2, it acts on the arachidonic acid that's there, and it generates prostaglandins. And those prostaglandins is what mediates the local inflammation. So when we were talking about these COX-2 specific drugs, the thought was that we're not doing anything with COX-1, we're only messing with COX-2, which COX-2 is primarily the enzyme that is mediating the local pain and inflammation. So that's the thought process, okay? Now, and from a theory standpoint, it sounds, I mean, it's very rational with regard to the way it's going to do. So one of the things that we see is that, so you got two things going on. You've got an anti-inflammatory action, and you've also got an analgesic. So the anti-inflammatory is taking away the inflammation. The analgesic is actually giving you the pain relief. And the pain relief appears to be that it's reducing bradykinin activity. So prostaglandins can result in bradykinin, and potentiation of bradykinin is called analgesic. So an analgesic is pain forming, analgesic is removing pain or anti-pain, okay? So what we find is that the analgesic effect is through the blockade of prostaglandins, which ultimately can reduce the effects of bradykinin, which is the pain component. And the anti-inflammatory actions are due to the blockade or the reduction in prostaglandins. So the prostaglandins are very important in the inflammatory process, and so that does it. Now, these drugs are also known to be fever reducing. We call them antipyrogenic. And there is actually in the brain what is called the CNS thermoregulatory center. And what happens when you develop a fever is you actually are getting production of pyrogens. Pyrogens are nothing more than fever-inducing compounds. And so what happens is that the NSAIDs reduce these antipyrogens. So most of the effects therapeutic are ultimately due to the inhibition of cyclooxygenase for these non-steroidal anti-inflammatory drugs. Do not worry, do not study this. I just want to point out some things to you. So just to give you an idea to put you into perspective. All right, so let me get, all right, so you can see my pointer here. All right, so just to show you is basically, here's arachidonic acid up here at the top of the, let me just circle. So up here is arachidonic acid, okay? Arachidonic acid is the precursor. So what we find is that cyclooxygenase 1 and 2, which are here, they actually produce what is called prostaglandin G2, which then gets converted to prostaglandin H2. And what we find is that prostaglandin H2 can actually produce a compound, prostaglandin D2, which can cause smooth muscle contraction and inhibit platelet aggregation. This PGH2 can form PGF2 alpha. PGF2 alpha causes smooth muscle contraction, can cause bronchoconstriction, actually can induce abortions. PGH2 can be converted to PGE2, prostaglandin E2, and that is a vasodilator, and it can produce some hyperalgesia, which means it can cause pain and cause fever. It can cause effects on the kidneys to cause urination, and it can actually affect the immune system. We see that PGH2 can also form thromboxane, which causes vasoconstriction and causes platelets to constrict. This PGH2 can form PGI2, prostacyclin, which causes vasodilation and inhibits platelet aggregation, and that can be converted to a 6-keto PGF alpha. So these precursors, starting from arachidonic acid, can cause or produce a number of effects depending on what the tissues are. So notice where the inhibition is occurring. The non-steroidal anti-inflammatory and the COX-2 inhibitors up here, they're blocking this action. So they're shutting it down here, okay? So the net effect is when we're using it as an anti-inflammatory, when we inhibit or block the effects of cyclooxygenase, we're not going to form PGG2, or if we form it, it's going to be in much lower quantities, which when we shut that off, it shuts down pretty much all these other substances, all these other prostaglandins. Some of these can be beneficial, some of them can be negative. So the problem is with the drugs that we have is they're effective, but they can have some detrimental effects. So all of the non-steroidal anti-inflammatory drugs, they all inhibit cyclooxygenase, every one of them, as I said to you a few minutes ago. So every one of them inhibit cyclooxygenase. And this inhibition of cyclooxygenase results in inhibition of prostaglandin synthesis, so we don't get the PGG2, and that accounts for most of its therapeutic effects. But, as I just said, inhibition of prostaglandins can be detrimental. And in fact, that's what happened. Is the number one thing that we worry about with NSAIDs is GI bleeds. Taking over-the-counter or taking non-steroidal anti-inflammatory drugs can result in GI bleeds. And when we talked about the GI drugs, remember I told you the NSAIDs are a major risk factor for producing ulcers. Okay, how does the ulceration and GI bleeds occur? Because one of the things is that we need prostaglandin to keep blood supply to the GI tract. And if we don't get good blood supply to the GI tract, then what's going to happen is basically we're going to get poor perfusion, poor blood flow, and the tissue is going to become weak and it's going to be susceptible to breakdown, okay? So one of the things that we find is that we have to be careful with how much of these anti-inflammatory drugs we take, not only how much, but as far as dose-wise, but how much we're on. One of the problems we run into is older people tend to have a lot of chronic inflammatory conditions. Their GI tract seems to be more susceptible. And also, as I told you a couple of weeks ago or a few weeks ago, older individuals, their pain receptors, they could have GI ulcers and GI hemorrhage and not feel any pain about it. In fact, one of the things we might find is suddenly they are anemic. And when they get anemic, then what we find is, where's the blood loss? We find out it's in the GI tract. So very common adverse effects of all of the GI drug, all of the NSAID drugs, is we see gastritis and ulceration. You can just refer to this as GI irritation, GI bleed, okay? Another thing that can happen is that these drugs can cause renal failure, because one of the things we find is the prostaglandins mediate renal function. So if we start using NSAIDs and we use too much of them, or a person is susceptible or has some renal function issues, then we can decrease the renal blood flow, and we can cause kidneys to shut down. We get sodium and water retention. We always worry about these NSAIDs because of this sodium and water retention to raise blood pressure. So people that have high blood pressure, we have to be very careful if they're on these drugs. We can see some edema accumulation because the body's not getting rid of the sodium in the water. We can see platelet dysfunction, so they interfere with platelets, because as I showed you with the last couple of that slide with all the structures and activities, is basically those are involved in clotting. Excuse me. Jason, you asked, so NSAIDs don't actually hurt the stomach or lining. They cause poor perfusion. So they, some NSAIDs can be, for example, the acetic acid NSAIDs, because they're acidic, can potentially be, can damage the lining. So there are some that can cause damage to lining, but most of them, we find the prostaglandins are necessary for good perfusion of the tissue. I think prostaglandins are involved in some of the mucus makeup, or generating mucus and so forth. So that inhibition does that. But as far as actually causing gastric ulceration, most of the formulations and everything that we have now, they've gone through to make sure there's no irritating effect. There's several. For example, I was hired to evaluate a new formulation of ibuprofen, and we did the studies to see. We compared it to the older formulations of ibuprofen. And this particular one, basically, we saw more gastritis and ulceration. And so it was never moved further. The drug company did not try to push it on, because they knew they could not get that past the FDA. But most of the actions that we see associated with this is due to probably mainly a reduction of blood flow to the GI tract. We do see people that are hypersensitive and have hypersensitivity reactions. They can have pulmonary, that can be pulmonary. And one of the big things, which actually one of the things I'm probably most proudest of that I did is myself and a few others. Back in 2005, we petitioned the FDA to get a stronger warning on the over-the-counter NSAIDs that warned of Stevens-Johnson syndrome and serious skin rashes. Prior to 2005, there was no warning about that. And we did that primarily based upon ibuprofen, but it went across the group. And so they did change the label based upon a citizen petition myself and about 5 other individuals wrote. So we still don't think the warning is as good as it can be. And we do know that in other countries there is a stronger warning, but it is improved. Now, those are NSAIDs, and aspirin sort of falls into the NSAID category, but aspirin is a little bit different. Some people will include aspirin as an NSAID. Some people talk about NSAIDs, which they talk about ibuprofen and naproxen and so forth. And by the way, the true non-steroidal anti-inflammatory drugs that we have that everybody would agree on that's available over the counter is ibuprofen and naproxen, okay? Some people include aspirin in that group. Other people talk about aspirin as separate. But from a standpoint, aspirin is non-steroidal, and it is an anti-inflammatory. Okay, so in theory, aspirin does fit into the category of NSAID. So one of the differences with aspirin is, whereas the other NSAIDs, they will bind to the cyclooxygenase reversibly, aspirin binds irreversibly. And So that's a big difference with aspirin, is that it is an irreversible binder to the COX. Okay, so that's sort of unique. We don't use aspirin as an anti-inflammatory because of a couple of things. One is we find that aspirin was many times more irritating to the stomach. Even though we had enteric-coated aspirin and buffer aspirin, we still saw aspirin, just with its chemical makeup, tended to be more irritating to the stomach. And so the other big thing is that with aspirin is a lot of people quit using aspirin because of Reye's syndrome. Okay, Reye's syndrome can occur in children, does not occur in adults due to aspirin. So many people quit using it in their kids and just never have used it as they've grown up. And so that's one of the things. And a lot of people would say, well, I can buy children's ibuprofen or children's Tylenol. We'll talk about Tylenol in just a few minutes. But aspirin itself, we rarely see it used as an anti-inflammatory. And actually aspirin is pretty good. Aspirin is probably very good for reducing or treating mild to moderate pain. It doesn't seem to be real effective if it's severe visceral pain, but a lot of the mild to moderate pain that most people use ibuprofen and so forth for, aspirin works pretty well. Aspirin also reduces elevated temperature. It's a good antipyretic, and that probably is acting through cyclooxygenase inhibition up into the brain. Another thing with temperatures is that we get interleukin-1, which is released from macrophages, which are white blood cells, that can contribute to temperature elevation. But aspirin is a good antipyretic. It is a good anti-inflammatory. What you see aspirin used for primarily now is for treatment or following people that have coronary artery disease. And people that have had strokes. We see this as aspirin being used as a prophylactic for those type of things. And that's what it's primarily used for, its platelet aggregation. So when people have had a heart attack or have had risk for heart attacks, we will put them on aspirin. Some of them usually what we see normally used is the 81 milligrams. This used to be St. Bear's and St. Joseph's used to put out a baby aspirin. And it was designed for use in small children. It was orange flavored and it was 81 milligrams. That's why, and it was small. So it was a little tiny orange pill. And so people got to referring to those as baby aspirin. Even cardiologists today will sometimes say, well, I want you to take a couple of baby aspirin. St. Joe's and some of these other companies that had these baby aspirins, because of the Reye's syndrome, quit marketing them as baby aspirin. They started marketing them as I think it's cardiovascular aspirin or cardiovascular formulation or whatever. But what aspirin does is it inhibits cyclooxygenase by irreversibly binding to it. And so actually that lasts, the way you get over an irreversible binding of an enzyme is you got to make new enzymes. And Rebecca, you're right. One of the concerns was a lot of people liked that orange flavor. And that was one concern we had years ago when it was marketed as a children's aspirin. What we found was that the orange flavor, kids would get into it and actually overdose with it because they'd sit there and eat a bottle of it. But when aspirin binds to the platelet, basically its effect lasts about 8 or 10 days, pretty much the life of the platelet. And because it's irreversible binding. The adverse effects, the number one thing is gastric upset, ulcers, including duodenal ulcers. There has been some hepatotoxicity that's at high dosages. Some people are sensitive to aspirin if they're asthmatics. That can be sometimes explained because prostaglandins may be involved in bronchoconstriction, and if you block it, it causes bronchoconstriction. There have been some rashes that have occurred, some renal toxicity where renal failures occurred. And the other one is, which I didn't list here, but let me put it here, is in children is the big concern, and why people don't use it is Reye's syndrome. And what Reye's syndrome occurred in kids. It doesn't occur in adults, but it's an encephalopathy. It can be fatal. And Reye's syndrome occurs in kids. And make sure you make a note of that. I didn't have it on here. That's typically a question that comes up because that's one of the major concerns with aspirin. So, that's one of the things I want you to definitely be aware of. Another thing that can occur is, by the way, on Reye's syndrome, typically it was kids that had viruses, and when given aspirin could develop this Reye's syndrome, which could be fatal. There's another thing called salicylism, which occurs with these acetic acid salicylate type drugs. The individuals, they will express this. They'll be throwing up, they're ringing in their ears, sometimes loss of hearing, may have some vertigo. Typically, when this start occurs, one of the things we look for, if people start hearing ring in their ears, we want to reduce the dosage or basically take off remove discontinue the aspirin. Now, one of the things that we did see is that we've seen people try to commit suicide with aspirin. It's not a pleasant death. It's nothing we had. But one of the things we did see is when kids would get into aspirin, the St. Joe's or the baby aspirins that were orange flavored, they would just, eat a whole bottle. So there is pretty significant toxicity that occurs when people either overdose intentionally or unintentionally. So one of the things we see is that aspirin has a direct action on the medulla, and so they start this very rapid breathing. It's called hyperpnea. And then they go into a respiratory alkalosis, and then that progresses to a metabolic acidosis. So they get respiratory depression, cardiotoxicity, glucose intolerance, and this can be life-threatening. And so we've seen people, and there's been numerous reports of individuals coming into the hospital where they've overdosed with aspirin. Don't see as much. People find there's other ways they can kill themselves, but every now and then we do see it. The way we treat it is basically we'll do gastric lavage to try to get any of the aspirin that's still in their stomach out so that they don't absorb it. And then what we're going to do is give them sodium bicarbonate infusions, really to try to make their urine alkaline and put out a lot of urine output. And the idea is it sort of neutralizes it and gets it out of their system. The big thing that you typically have to worry is when they go into this, they do develop a hyperthermia, which is a little paradoxical in the sense that you take an antipyretic, but in high doses, it actually produces a hyperthermia. And we do see that a lot of times they develop electrolyte imbalances, which you've got to stay on top of. Now, there's several other agents. I'm just going to mention these. There's a few of these NSAIDs that we're going to talk about that I just want you to be aware of because they're there. So we have things like these are not salicylates. Aspirin is considered a salicylate, but we have magnesium, sodium, and salicylate. These are some of these drugs. They are pretty good anti-inflammatory drugs. They're not as effective as a analgesic. Sometimes these drugs may be used in asthmatics or people with bleeding disorders. But again, we typically see some of the other drugs we're going to talk about used. I've already talked about the NSAID-induced toxicity, which is due to blockade of COX-1, cyclooxygenase 1. The COX-2s were designed to overcome this. And the idea was that at clinical dosages, that theoretically you could get this differential. In reality, that was more theory, because the theory was that only COX-2 was expressed in areas of inflammation. And there was some data that suggested that that may not be exactly correct. So let's see. Yeah. So basically, what we have here's the example is with COX-2, you see under peripheral inflammation, COX-2 gets upregulated in the inflammatory cells. Then basically it comes down and gets peripheral sensitization. So the idea here was, all I was pointing out with this one is that COX-2 theoretically gets upregulated during inflammation, so it's more susceptible. And if we can block it, then we don't worry about some of the other things. Over here is with the central cytokines, we get COX-2 upregulation, which can account for that. And that may be part of the antipyretic action. But again, the problem with that is that Vioxx and Bextra, valdecoxib was Bextra. Those two have been pulled off the market. So we have celecoxib, which is Celebrex, which one of the things to be aware of is your patients, many of your patients may be on Celexa. So one of the things is they can confuse Celebrex with Celexa. So be aware of that. But there's one other drug which was actually considered somewhat non-selective. It's called Mobic or meloxicam, which we see used a lot now. It does have some selectivity, but it also has some COX-1 activity, but it's weaker there. And we saw once that Vioxx and Bextra got pulled off, we saw more Mobic being used. Yeah. So let me cover a couple more slides and then we'll take our first break here. So the COX-2 inhibitors, they were actually developed to avoid the side effects. The idea was if we could only block the COX-2, we wouldn't get the GI ulceration, the GI irritation. That was their main reason. They are still competitive inhibitors. They're not irreversible. They did produce analgesia. They did reduce fever. They were anti-inflammatory. Those were all comparative. But the other big thing was that people argued there was no effect on platelet aggregation. And so that was all what was touted as being the advantage. What we did see is COX-2 inhibitors, Celebrex. It was actually a sulfonamide. So anytime you have a sulfur, you've got a potential for rashes. The meloxicam or Mobic, basically, it had fewer toxicities, but it wasn't quite as selective. Still had some of the effects of COX-1 inhibitors. And so that was why we see more meloxicam used. We still see some Celebrex used, but it just depends on the doctor. All right, let's see. All right, so let's go ahead and take our break. Let's come back at 15 after the hour, and I'm going to pick up and talk about some of these non-selective COX inhibitors on there. We're going to pick back up on the non-selective inhibiting. Again, non-selective is basically they're doing COX-1 and COX-2. So that's what we're looking at here. All right. And Aiden, I don't know when you want to do the attendance poll or not, but we need to just remember to do that. Okay. All right.
I'll do it somewhere after the second break, Doctor.
Okay, no problem. All right. So these other inhibitors, and again, if they're not in red, one of the things that I want you to do is just be aware of them. You hear of them, but again, I'm going to focus on some of the ones that are either used more frequently. But diclofenac is basically what you're going to see is that a lot of these drugs that we backed off of from a standpoint of using them. What in reality, we probably see ibuprofen, we see naproxen used, we see Mobic used, Celebrex has gone down. These are the big ones. Of course, we see Tylenol being used. These are the big ones that are there, and we see the most frequently. These other drugs are used to some extent. They're not, again, there's a few differences. Now, one of them is a drug which we'll mention is ketorolac. We see that used in the hospital sometimes, but a very, very limited thing. But the main reason, a lot of these drugs pretty much have very similar actions. We'll see a little bit difference in pharmacokinetics, but the other big thing is the side effects. So with diclofenac, we basically saw that a significant number of patients had adverse effects, which they don't tolerate the drug very well. One of the big things that we saw was GI bleeding, which is common with all of these drugs. Another thing that we did see is compared to the others, we saw some elevation of the serum aminotransferases, which is a liver enzyme, and that occurred more frequently. And so a lot of people backed off of this, especially if they were concerned about liver toxicity. Diflunisal, it's actually was derived from salicylic acid. But this one was used for quite a while, or felt like it was more effective in patients that had cancer, and we also saw it in dental pain. In fact, one of the things that you will see is a lot of these drugs, one of the big things that we saw was these drugs actually were used were developed for a lot of use in dental pain. All of these drugs, all of these non-selective drugs, have a black box warning for for cardiovascular risk and also for GI risk. Their warning for all of them can produce serious skin reactions. That warning in 2005 was elevated, so that was actually in the warning section. It was elevated up further in the label. But again, with these diflunisal, basically with this drug, you had to worry if anybody had renal or liver disease, because if you its ability to be cleared from the body was depending on metabolism by the liver, and then also clearing through the kidneys. So if you had somebody with renal liver disease, and sometimes in advanced cancer, we may see that's a problem. Itidolac was a little bit more selective for COX-2. They used it sometimes for postoperative pain. It seemed to work pretty well, so you saw it primarily used in the hospital. This drug was it's now available as a generic, and one of the problems it did give good relief, but it seemed to have a little less gastric toxicity than the other non-selective NSAIDs. One of the things that was interesting is you don't see it used quite as much, which you would think that with the COX-2, but what I think happened with this one was with the heavy COX-2 introduction that occurred initially, this drug sort of lost popularity and it never regained it when it came back. So it's still around, but not used. Now, there's a lot of drugs that are what we call the propionic acids. This is the same class that ibuprofen is in. And phenylprofen was one. All of them have very similar therapeutic efficacy. Some of them have a little bit more of have some side effect issues, like phenylprofen, very similar to ibuprofen, same class of NSAIDs. But it did develop, this one had a propensity to produce some interstitial nephritis, so an inflammatory condition in the kidneys. So that was where it sort of dropped popularity or moved it lower in the level. Fluorobuprofen, another thing similar to ibuprofen. This one seems to have some other actions. For example, it's been shown to affect the TNF-alpha. It also can affect nitric oxide. One of the problems that you saw with this one is there's a number of what we call stereoisomers or enantiomers, and those enantiomers may be metabolized differently, which can create some problems. There were some side effects occurred in a few patients that were sort of rare, which included some ataxia and tremor and myoclonus. You really don't think of those when you're thinking about an NSAID, okay? Now, ketoprofen. Ketoprofen is used still quite frequently. What we've seen with it is it does seem to work pretty well. We see it used a lot of times for mild to moderate pain, see it used in everything. A lot of these drugs are basically used for osteoarthritis or rheumatoid arthritis, or their big common use of these is dysmenorrhea, people that are having pain with their periods. It really is not superior to the other drugs. You see some docs that like this. But again, ketoprofen, if you see the ibuprofen, ketoprofen is going to be very similar. Ketorolac, we talked about. The big thing about ketorolac, it's really not it doesn't have a lot of good anti-inflammatory actions. It has some, but not good. It is a good analgesic. So a lot of times they've used this one, as I've said, following surgery for a short period of time. The biggest problem with ketorolac is you can have some pretty significant renal toxicity. That's why its use is very limited. So typically the patients are not on it but just a few days. Meclofenamate, mefenamic acid, these are, again, cyclooxygenase. One of the problems with these is that used with oral anticoagulants, it can make them greater propensity to bleed. Again, a lot of these limited use, not as effective. And as new drugs came out, what we saw was these other drugs, the potential for using them for long term, there was more toxicities associated with them. Nabumetone actually gets converted to an acetic acid derivative. The big thing about it was that it had a long half-life, so that was always a nice thing to think about as a long half-life NSAID. It's very similar to naproxen, but we did see some photosensitivity and what they call pseudoporphyria that occurred, again, not used very often. Now, let's move to a couple of the ones that we see used almost all the time. Naproxen. All right, naproxen comes as a single enantiomer, which means that basically it's a very pure form of the drug. The GI toxicity compared to a lot of the other drugs is not as bad, but compared to ibuprofen, it's a little bit worse. Personally, what I find is naproxen, as you know, is available over the counter. I have found, and this is just my personal observation, is that for musculoskeletal things, naproxen seems to work a little bit better. That's from me, I see that. So if I, basically have a hurt knee or sprained ankle or something like that, I usually will take naproxen over ibuprofen. And one thing to keep in mind is all of these are NSAIDs. So a lot of people, they think of either ibuprofen, naproxen, or acetaminophen. One thing to keep in mind is this, is the naproxen and ibuprofen, they have anti-inflammatory properties. Acetaminophen is very, very poor anti-inflammatory. Acetaminophen is a good analgesic. Acetaminophen is a good, or can be a good antipyretic. But as far as anti-inflammation, no, the acetaminophen is not going to be a good anti-inflammatory. Some people think it is because the analgesic aspects make it not hurt as much, and people are associating the inflammation with that. But acetaminophen is not going to be an effective anti-inflammatory. Oxyprozin, available. It's a long half-life. We see these long half-life drugs to potentially treat gout. Phenylbutazone was on here, but the problem we ran into it was it produced aplastic anemia, and the aplastic anemia was why the drug got pulled off. So, Tolmetin was another drug that was designed to really, they hope to use it in gout, but its short half-life just really made it too short, so we don't see it. Also, it could produce some thrombocytopenia, which was that was rare, but it was still a concern. And then there's another drug which we have seen used. Is one of the reasons is that it tends to increase or prolong the duration of action because it goes through intrahepatic cycling. That's Sulindac. It is converted. It is a prodrug and converted to another thing. And one of the things was it was believed to not produce as much kidney toxicity. That was that has been one reason why people have used it. We have seen kidney toxicity reported, but we also saw, as with all of the NSAIDs, we have seen basically serious skin reactions, SGS and 10. Piroxicam, long half-life, that was its big advantage, but we do see some, again, GI toxicity. Probably the oxycams produce more GI toxicity than any of the other NSAIDs. People have complained of being a little dizzy when taking this and some ringing of the ears. We've also seen serious skin reactions. Then we have indomethacin. Now, indomethacin we see used more for gout, probably used more for gout because its side effect profile was not as good. We actually saw that the newer agents, including even some of the things, well, definitely the COX-2 inhibitors, we saw them actually produce less side effects. So one of the problems with indomethacin is that it will work well for gout, but for the acute treatment of gout, but from long term, we still have to be really concerned. In fact, a lot of the other drugs may actually work better because their side effect profile is much better. So one of the things that I mentioned renal function several times. Let me just show you, let me get this thing out of the way here. Show you how that the NSAIDs in general can interfere with renal function. So let's just follow through this here and just real quickly. So anytime your renal blood flow goes down, for whatever reason, okay, that will, one, is it will activate the renin-angiotensin system. And the renin-angiotensin system can cause causes the kidney to produce prostaglandins. And those prostaglandins actually can cause renal vasodilation, which will normalize your renal function. The vasodilation can will basically produce an increase in this. Okay, it can also, when your renal blood flow goes down, it'll activate the central nervous system, and what that can do is that can cause norepinephrine release, and that can cause renal vasoconstriction. Okay, which is not what you really want. What you want to do is because when you get renal vasoconstriction, you're decreasing blood flow through the kidneys, and that causes the renal function to go down. So one of the things that you find here is that when you get this renal prostaglandin synthesis, it offsets this renal vasoconstriction. So the biggest problem is when you use an NSAID, non-steroidal anti-inflammatory drug, including ibuprofen, in fact, when ibuprofen was being approved for to go over the counter, the National Kidney Foundation opposed it strongly. And the reason they opposed it was their concern was being over the counter, people would take too much ibuprofen, and as a result of that, could have their kidneys shut down. So what happens is these NSAIDs, because they're blocking the production of prostaglandins, they can interfere with this renal prostaglandin synthesis here, which can keep the renal vasodilation from occurring and keeping the normalization occurring. So the big thing is that NSAIDs we worry about with their renal toxicity is basically primarily by inhibiting prostaglandins, they prevent renal vasodilation, and it prevents renal functioning. It drops renal blood flow. So that's the big thing, is the renal vasodilation we want to maintain. And that's why we're careful about them. We're also careful about not only with patients taking them too often, because one of the concerns you have is being over the counter. Patient takes one for, let's say you got a person that's got some renal dysfunction. So what that person does is had a headache. So they take this and it's a bad headache. And so maybe they've been studying pharmacology for like 3 hours. They got this splitting headache. So what happens is basically they take it and 30 or 40 minutes later, it's still not working, or they still got the headache. So they pop another one or two of them. So we do see people, and then, an hour and a half later, headache has maybe subsided a little bit, still going, they maybe take another. So what we worry about is somebody, especially with renal function, elderly people, which have a naturally decreased renal function. People with high blood pressure, not only can it raise your blood pressure, but it can decrease your renal flow. So that's one of the big concerns we have with that. So what the renal effects of what the prostaglandins do is they redistribute the blood flow in the kidney. They dilate the vascular beds, which allow the blood flow to go through the kidney and filter the blood, okay? So, and prostaglandins, by adjusting this, also mediate sodium and potassium homeostasis. So basically it helps you get rid of the sodium, gets rid, and potassium, and maintains that. And when you have renal insufficiency due to age, due to some other underlying disease, if you have congestive heart failure or even cirrhosis, the prostaglandins actually are one of the things that are trying to maintain your renal flow. So if we block these effects of the prostaglandins by blocking the cyclooxygenase, then what happens there is basically we're shutting off a compensatory mechanism and causing the kidneys to shut down. So that's exactly what we just showed you, is by inhibiting the renal prostaglandin synthesis. So NSAIDs are going to block cyclooxygenase. That leads to unopposed vasoconstriction, and that shuts. And when the kidneys vasoconstriction occurs in the kidneys, what's going to happen is basically that's going to prevent the kidneys from being perfused. They become ischemic, and your kidneys shut down. We see that renal sodium retention, that's a big concern, is we see that up to 25% of patients that are on NSAIDs may actually have a significant sodium retention. That's more common in patients that have mild heart failure or liver disease. People gain weight, they get some peripheral edema, so the kidneys are just not able to function there. We also see with people that are hypertensive, a big concern is that we can get an increase in blood pressure. Typically, the average increase in a mean arterial pressure of a hypertensive patient or a person taking NSAIDs that may be hypertensive is somewhere between 5 to 10 millimeters of mercury. Older patients may get a little bit more, and one of the things that happens is they may be taking NSAIDs, which the doctor may not know because they're taking them over the counter. And one of the things that we may actually see is that these individuals may actually be perceived as being hypertensive when it's really drug-induced. So one of the things that can happen is they can put them on antihypertensive therapy, and now you're dealing with them being on, some sort of therapy that's there. We can get some hyperkalemia. Typically it's mild, but in some patients it may actually contribute to cardiac arrest. So sort of to summarize these NSAID toxicities, we have one of the biggest ones that occurs more frequently is probably GI. We get the gastric ulceration. That's probably our number one problem that we see with these particular substances. So we always have to be concerned with hold on just a second. We had a minor avalanche. We had a slight topple of some bins, but we always have to be concerned about GI, especially if people are using these on a regular basis or taking a lot of them over a short period of time. Cardiovascular component, we're worried about blood pressure going up. We're also worried about kidney failure, and sodium and potassium imbalances can be with these NSAIDs. Now, are we going to see this in most people that are taking these type of things? No. But we do see it in a significant number of patients. It's enough to be aware of. And then, of course, the other thing that we got to worry about is basically skin. These drugs are known to cause SJS and 10. So if a person develops a rash, blisters, red spots, that needs to be addressed immediately. So they should stop taking the drug. Should stop taking the drugs. And we should continue to, we need to move them there and monitor them and make sure that the rash and blistering doesn't get worse. With the GI toxicities, we start off a lot of times with just some gastritis, but it can progress. We have to be very careful. So typically what will happen is the gastritis gets worse, develops an ulcer. That ulcer will then go into, they can start having hemorrhaging. And when the hemorrhaging, they can go to actually perforation. And so one of the things we see is that they can develop anemia from this slow bleed with GI. And, when you look at it, back in 97, there was like 16,500 patients in 1997 that died of GI bleeds, okay? Patients that come in hospitalized with GI bleeds that have been produced by NSAIDs, that's 5 to 10% of the hospitalized patients. And we have a lot of them that become unnoticed. But one of the things you need to be aware of in particular is some of the signs of anemia could be, fatigue, and signs could be analogous with some of the signs that we see with depression and so forth. So basically, we have to be very, very careful with regard to that. Okay. All right. So let's move away from NSAIDs. And acetaminophen, like I said before, sometimes it's included in the NSAID category. I sort of, I don't include it as an NSAID because it has very poor anti-inflammatory actions. In fact, a lot of people say it's negligible. So acetaminophen, although it will relieve pain and it will relieve fever, it is not going to be anti-inflammatory. It's not going to be good for anti-rheumatic, and it's not going to be used for gout. I mean, basically, if it's used in any of those cases, it is primarily being used for the pain, with the idea that once the pain is relieved, then basically they think the inflammation has gone. But that's not the case, okay? So what it's really doing, it's primarily what it's going to do is it relieves pain, but it's not taking care of that underlying, the underlying inflammation. As far as analgesic, many people would consider it that it's as effective as aspirin, as a antipyretic, fever reducing. Most people would consider it as effective. A lot of times we see people taking acetaminophen because they have peptic ulcer, because acetaminophen does not cause the GI bleeds. We see it in people that are taking gout, oral anticoagulants, any clotting disorders, those type of things. We see, because it has very minimal effect on the bleeding aspect, whereas NSAIDs do, that, and also we use it for kids because basically we don't want to use aspirin in kids because of the potential for Reye's syndrome. One of the biggest problems with acetaminophen that we first came out was liver damage. And so the big concern is there was a whole advertising campaign that came out that was called Know Your Dose, which was to limit the amount of acetaminophen somebody takes, mainly because of too much can cause liver damage. One of the big concerns we have is with individuals drinking alcohol. And when they're drinking alcohol, one of the things that can happen is the alcohol and the acetaminophen combination can even be worse on your liver. So it can produce liver necrosis and cirrhosis. So we have to really be careful with how much acetaminophen a patient takes. And our concern is really because it's over the counter. And being over the counter, what happens is that basically people will dose on their own. They're not being supervised with the acetaminophen, and that can create a real problem. We do see people think that since it's over the counter, it's completely safe. Otherwise, it wouldn't be sold over the counter. We see people think that because of the acetaminophen, everybody uses it, then they don't anticipate, there being a problem, and, they consider it very safe. So they tend to take more than they need. So and the other thing that sometimes happen is they have a prescription for another analgesic, like an opioid, but things like hydrocodone, oxycodone, even tramadol, sometimes are combination products that include acetaminophen. So the patient may not be aware that they are taking acetaminophen with that aspect of it, and they may be taking over-the-counter acetaminophen. So the combination of the two, they may be thinking, I'm going to take more acetaminophen, which will limit my how much tramadol or oxycodone I have to take. And so they are thinking it's helping, but they may actually overdose. So when you look at a lot of these agents, NSAIDs, aspirin, acetaminophen, all of them have been used to reduce fever. So what we have here is that anytime that body temperature goes up, whether it's a fever, whether it's being out in the sun and developing heat stroke, but that increased temperature is actually all being mediated in the hypothalamus. People sometimes forget that we're looking at these drugs are actually working in the brain to do that. Non-steroidal anti-inflammatory drugs generally are not real effective at, they're not as effective as other drugs as decreasing body temperature. Some of these can, some of the NSAIDs can, but it's not across the board. Okay, again, they're reducing inflammation. Things like ibuprofen, naproxen, things like that, those will reduce fever. Okay, and one thing you need to be aware of is that there is a move by a lot of people to say, okay, there are ways to reduce body temperature without using drugs. Most fevers are self-limiting, especially the fevers under 102. And a lot of people that don't want to use drugs, what they will suggest is basically, tepid baths and just letting it run its course. What we do know is that when you have an inflammation, your white blood cells come in, and those leukocytes basically they release substances which are called pyrogens. And one of the things that fever is for is the idea is by heating up the fever, what's going to or heating up the body temperature, it's going to kill some of the bacteria. So what we find is the leukocytes release these pyrogens, and these pyrogens then go to the thermoregulatory center in the hypothalamus and send the signal to increase the temperature. Typically, that's associated with an increase in the prostaglandins in the brain. So aspirin actually has its antipyretic effect, because what it does is it interferes with these it interferes with the prostaglandins. So any of the NSAIDs that do have some antipyretic action basically are able to get into the brain and decrease the prostaglandin levels. On all of the NSAIDs and Tylenol, we're going to include Tylenol here too, because a warning came out in 2013. The FDA sent a warning out. I don't know if you guys saw it, but basically the 2013, the FDA made increase the warnings that even acetaminophen can produce serious skin rashes like SJS and 10. So right now, I'm not aware that aspirin can do it, but any of the NSAIDs and Tylenol can produce photosensitivity, rashes, although aspirin can produce a rash. But SJS and 10 are a potential thing with any of these drugs. So if the other thing I want you to be aware of is that as far as drug interactions, what are significant drug interactions with these NSAIDs? One of the big ones are anticoagulants, okay? So one of the things which we want to do is if someone is taking an anticoagulant, we don't like for them to take NSAIDs. Now, some docs will prescribe, they may be on warfarin, they may be on baby aspirin or 325 milligrams of aspirin. So there's sometimes when we have what is called double therapy, which they're on an anticoagulant and aspirin. But one of the things that we have is that with anticoagulants, many people that are on an anticoagulant, they will be explicitly told, do not take NSAIDs. And the reason for that is primarily that you can increase the chance of bleeding. This next one, I definitely want you to know, okay? Here's a big concern, and this can be a significant clinical issue. Patient on lithium, which you will prescribe, okay? What we find is that non-steroidal NSAIDs, non-steroidal anti-inflammatory drugs, actually inhibit the renal elimination of lithium. So you don't want someone taking NSAIDs while they're on lithium, because what that's going to do is it inhibits the elimination of lithium, and lithium levels are going to increase, and lithium is one of these low safety index drugs because narrow therapeutic index. Very little change in lithium levels can result in significant toxicity, okay? So a very important thing is anybody that is on lithium, your patients should be told not to take drugs over the counter that are NSAIDs, and they also need to be aware that shouldn't take any combination drug, analgesic, that is prescribed that has an NSAID in it. Ibuprofen is the most common one. That's probably the most significant drug interaction that you'll see with regard to the NSAIDs. And although it's not in red here because I couldn't make it in red with this table, I want you to asterisk. I can almost guarantee you're going to see it in one way or the other. Another important thing to remember is this interaction is occurring at the kidneys. Lithium is not metabolized through the liver, okay? Lithium is completely excreted through the kidneys. The liver doesn't come into play. So the drug interaction is at the kidneys. It is not at the liver simply because lithium does not go through the liver, okay? With people with high blood pressure, one of the concerns we have is that you don't want them, you want to be very careful about using them. The NSAIDs can cause fluid retention, they can cause edema, they can actually offset some of the antihypertensive effects. Okay, so let's take our afternoon break here. Let's come back on the hour because we're at a good place to break. I'm going to talk about gout. We will probably get gout done before our lunch break. We may get into the next group of analgesics, but let's come back on the hour and we'll pick back up on gout, which is going to use some of these NSAIDs, but we're going to use some other drugs too. Okay? All right. I'll see you guys on the hour. That's about 9 minutes. Let's go ahead and pick up with the next group of drugs. And actually, we use some of the drugs, the NSAIDs and so forth. It's interesting. When I first started in pharmacology and so forth, I always thought that gout was one of those diseases that you rarely saw. It was usually, the way it was taught to me, it was like a disease of the rich, where people were eating these really high foods and stuff like that. And then, over the years, I've discovered that the gout is basically a big problem with a lot of people. Several people that have gout. It's just surprising. There are people that I know that's in our socioeconomic group and everything, but pretty easy disease to understand in one sense. What happens is that basically you get the buildup of sodium urate crystals. Basically, and the sentence here is not complete, but it said basically the deposition occurs particularly in the joints. And so it becomes very painful. And does anybody know which joint is the most susceptible, where they usually find it? Which joints? See, everybody almost knows that. It's like the big toe. And why the big toe is the one that seems to, when you think about it, you think almost like, for example, something like the knee or elbow or some other thing like that would be where you would find it. But basically, these sodium urate crystals, they deposit, and what you get is a buildup of uric acid. And basically, just like when you get areas that are supersaturated, the uric acid then basically precipitates out, and these crystals, when they precipitate out, basically form a very painful, the crystals are, pointy and sharp, and so that creates the pain. So typically what we're going to see is the acute attacks. We will see indomethacin being used, naproxen being used, or some other NSAIDs. Those are fairly common. We don't use aspirin, and the reason for that is that aspirin can actually make it worse. What aspirin can do is it increases at low doses of aspirin, which you would most likely use, it basically inhibits uric acid secretion in the renal tubules, and as a result of that, it actually precipitates more there. So it's always it's a concern there. What we do see used for more long-term things is a drug called colchicine. And colchicine, what it actually does is it will bind up tubulin in the white blood cells, and that prevents the polymerization. So it's sort of a structurally arrangement that occurs in the microtubules. And so what that does is it it inhibits the phagocytic activity of these white blood cells. And so what it does is that it prevents the cells from actually getting down to where the uric acid is deposed. So in essence, by inhibiting the input of those white cells there, what you're doing is you're decreasing the inflammatory response. And that's one of the uric acid crystals there. They initiate an inflammatory response, and after that, you get the pain and you get the precipitation of the crystal, even more precipitation of the crystals. So what we're going to see is typically for the acute effect, we're going to see NSAIDs being used, things indomethacin, naproxen, very common things, anything but aspirin. You're not going to use Tylenol. The Tylenol can be used as an analgesic effect, but one of the things that you don't want is the Tylenol is not going to be anti-inflammatory. So one of the things we have is we're treating these drugs or treating this condition on an acute basis. We want to get rid of the acute pain. The other thing we want to do is we want to treat it chronically to get around to prevent these crystals from forming in the future. So the prophylaxis, so we've got an acute treatment, which the person usually presents with the severe pain. A lot of people with pain in their big toe pretty much suspect that they've got gout. One of the things we're going to do is we're going to adjust their diet because we're going to get rid of some foods that can build up uric acid. But the other thing is we're going to do is we'll use a drug like allopurinol. And so what allopurinol does is basically it inhibits xanthine oxidase. And the reason that works is because xanthine gets converted to uric acid. So if we inhibit the enzyme that makes the conversion of xanthine to uric acid, then we reduce the amount of uric acid, we reduce the plasma urate levels, and therefore by reducing the overall urate and uric acid, there means there's less possibility of developing these crystals. We also can use, we may use drugs like sulfonylurea or probenecid. These are what we call uricosuric drugs. What uricosuric drugs do is basically what they do is they increase this excretion. So what these drugs do is when uric acid gets down into the kidney tubules, it will be reabsorbed. Sulfonylurea and probenecid probably one used more frequently. Probenecid will prevent this reabsorption, which means the uric acid goes on out into the urine and you excrete it. So the approach that we have for treating people with gout is, number one, is what we're going to do is we'll treat the acute pain, typically with, an NSAID. But then from a prophylactic aspect is we're going to use a drug like allopurinol is very commonly used. And we may also use uricosuric drugs such as probenecid, which will increase it. So we decrease the amount of uric acid that's being produced. We increase the excretion of it, so it's getting out of our body. The other thing that we're doing when people are using these drugs, we're going to tell them, we want you to drink a lot of water. Because what we don't want is that you've got drugs that are trying to increase the excretion, and what happens is that you increase the amount of uric acid in the kidneys or in the, the renal tubules. And what happens is because there's not enough fluid there, it becomes supersaturated and you actually get crystals in the kidney. So the problem is these sulfonylurea and probenecids, they actually produce a little bit more toxicity than allopurinol. The allopurinol, one of the big things we want to watch for is particularly it has a high potential to produce serious skin reactions. So if you look at this schematic here, what you have is you have purines, which we take into our diet. Arnold, you asked about what happens to the extra xanthine. The xanthine, it'll be a feedback inhibition, so the xanthine will go down. So basically, we'll get rid of the xanthine. The xanthine can be moved. Now, part of this is we're taking in, so if you look at this diagram here, so we're taking purines in primarily from our diet. So one of the things that we hope is to drop the xanthine is that the xanthine is going to, if we get them eating correctly, then they're going to reduce the amount of xanthine, which is going to go down there. But the xanthine can be excreted. So what happens is you take these purines then through your diet. That's converted to hypoxanthine, and then xanthine oxidase will convert hypoxanthine to xanthine, and then xanthine oxidase will produce the xanthine to uric acid. So one of the things we have is allopurinol, shuts off this synthesis. It's going to block xanthine oxidase. Okay, so without the allopurinol, what's going to happen is the uric acid basically forms these urate crystals. And one of the things that will happen is these urate crystals, they will be phagocytized by white blood cells. And what we can do is colchicine can releases or basically inhibits this phagocytosis and release of these crystals, which can cause inflammation elsewhere. And then typically what's going to happen, the urate crystals, what we want to do is they're normally going to be excreted out through the kidneys, and urate will be picked back up in the by the tubules by being reabsorbed, but we're going to use the probenecid or sulfentrazone to cause that to excrete. So bottom line for gout is what we're going to do is we need to reduce the amount of uric acid because what's happening is we've got too much uric acid being generated. It gets a high concentration, it precipitates out, gets deposited in the, so anything we can do, so we start by diet, and the diet is to reduce the amount of purines taking into the body. Then we can use drugs to decrease the amount of uric acid that is produced. We can use drugs to get more of it excreted, and we can use drugs to basically, when the crystals get tied up, basically they can be released with other lysosomal enzymes and create inflammation. So we can use a multiple approach. Allopurinol seems to be one of the most common ways that we try to do that. So, yeah, so this is sort of a summary slide of what happens here with NSAIDs in general, okay? Phospholipids get broken down by phospholipase A to form arachidonic acid, and arachidonic acid, the enzyme is cyclooxygenase. That's the rate-limiting enzyme. So cyclooxygenase basically forms prostaglandins, thromboxans, and prostacyclin, okay? So arachidonic acid can also be used to form leukotrienes. So what happens here is that all the NSAIDs will inhibit cyclooxygenase. Now, that occurs with the salicylic acid. It occurs with propionic acids, which include ibuprofen, naproxen. So the key point here is by inhibiting cyclooxygenase, we inhibit the formation of prostaglandins, which is decreases the inflammation. Now, at the bottom of this box on the left, you see paracetamol. That is the British spelling or the British term for acetaminophen. Okay, so paracetamol is acetaminophen. And again, remember, key points: NSAIDs basically inhibit cyclooxygenase. That accounts for their therapeutic benefit. It also accounts for their side effects. Aspirin irreversibly binds to cyclooxygenase, so it inhibits prostaglandins also. It inhibits cyclooxygenase. The big thing about aspirin is it's an irreversible binding, whereas the other NSAIDs are reversible. Acetaminophen is an antipyretic, so it's used for fever, and it's used for pain. It has no anti-inflammatory actions. Okay, those are sort of a key point with regard to these particular drugs. Okay, all right, so that concludes our analgesics, non-steroidal analgesics, and so forth. The next group that we're going to move to, so these are considered a lot of times non-narcotic analgesics and antipyretics, okay? So let's move, let me get to the next slides, which should be the opioids. I think I may listed them as analgesics. Let's make sure that's them. Yeah. So what I'm going to do here is, and by the way, Aiden, we will probably in about 15 or 20 minutes, figure on a roughly 15 minutes, we will go to, give them the first 4 questions that I sent you. I think you should have gotten them yesterday, if I'm not mistaken.
Yes, Doctor. They're ready in a poll as one poll to be launched.
Okay, good. So now we're moving from the analgesics, which are the pain relievers. We're now moving to all the ones we've talked about before are non-narcotic. Okay, now we're moving to the narcotic analgesics in general, and these are primarily going to be the opioids. All right. All right, so let's go to this. So the opioids, we start with, and most of you probably heard a big thing about the opioid crisis. There is also a number of, there is also all sorts of media about, that this is, you've seen it with regard to the lawsuits and everything about overprescribing for the opioids. So there's a lot of information that is coming out there. Some of this information is good. Some of this information may not necessarily be correct. Some of it is, there's a lot of other things too that's going to come out. You're going to see a lot more things. Now, one of the things that I will tell you is that with all of the emphasis on the opioids, we have forgotten about the other drugs. In fact, there was a thing that talked about we have an opioid crisis, but behind the opioid crisis is a benzodiazepine crisis. So there's the issue about the issues with CBD oil and oh shoot, what's it called? And illegal and marijuana or legalized marijuana, medicinal marijuana. So those are all issues that come into play with this. And in fact, the FDA, I don't know if you guys heard this, but the FDA just sent out letters to some of the manufacturers of the CBD oil to basically that they cannot market them. So we'll see how that's going to happen here. All right. So let's look at the opioids. All right. So prototypical opioid is going to be morphine. Morphine is obtained from the poppy. The poppy's botanical name is Papera somniferum. And basically, if you take the seed pods and you make an incision, what's in that seed pod, it exudes a white substance, and that ultimately turns to sort of a, when it's exposed to air, turns to sort of a brown gum. Okay, that brown gum is what is called crude opium. Okay, now this opium contains a number of substances, not just morphine. Morphine is the principal one, but there's a number of other what we refer to as alkaloids that are present there. So when you get the opium poppy, there's other things in it other than just morphine. So when we look at opioids, and sometimes we use opiates. Opiates are, if you want to be split hairs about it, many people use opioids and opiates interchangeably. Opioids are the actual, or we see them where that these can be either natural substances such as the morphine, or they can also be synthetic compounds, things like paradol. But and so we're not going to differentiate between opioids and opiates. We're looking at that these compounds all produce a morphine-like effect. A lot of people may refer to it as a narcosis. Okay, these compounds bind to specific receptors known as opioid receptors. And they primarily are used, we do see some other uses, but they're primarily used as analgesics or substances to relieve pain, or the other thing that people describe is they relieve the anxiety associated with pain. One of the things that you see is we have a number of compounds that we're going to be talking about here. So when you look at the opioids, we have the drugs that are referred to as the strong agonist, okay? These are the ones that bind really well to the receptor. These include morphine. They include meperidine, Demerol, which is primarily used in the hospital. Methadone, which, remember, methadone is not only used for, everybody thinks of methadone as being what we use it for detoxing, but methadone is a very good analgesic. They use it for pain relief. And in fact, what we saw when Oxycontin was going really strong, a lot of people were moving back to methadone to use it as a pain reliever. The problem with methadone is that when people are taking methadone, there can be a stigma associated with it, because if they're using it for pain relief, people may presume that they're using it for instead using it because they're addicted to morphine. The other thing about methadone I'll mention now is methadone has a very long half-life, and one of the things is that we've had a lot of overdoses with methadone because of that long half-life. The clinicians may not have been aware of that. Of course, what has gotten in the news lately has been fentanyl, because it is probably one of our most potent opioids, and it's a synthetic. And but the fentanyl has been showing up mixed in with heroin. And I don't know if you know it or not, but heroin actually was designed, and when it was synthesized, the idea was it would replace the morphine that people are addicted to. People didn't, when they were designing it, did not realize at the time that the heroin had its own addicting properties. So these are the strong agonists. These are the potent drugs, okay? Then we have the moderate ones, which include things like codeine or propoxyphene. Then we have the mixed agonist and antagonist. These have gotten a lot of press because this is, for example, the butorphanol and buprenorphine. These have been used for detox. We also have nalbuphine and pitazicine, which are not used very much. And then, of course, we have the antagonist. We have naloxone, which is the antagonist, and we have naltrexone, which is also an antagonist. In fact, one of the things with naloxone has been we've discovered that we've had several shortages of naloxone, and then there's been discussion about whether that when someone actually prescribes a narcotic, they should. There's the debate as to whether they should at the same time prescribe naloxone in case of overdose. Narcan is the universal. I mean, if anybody is suspected of overdosing with an opiate, then they give them Narcan. One of the things we're running into on the street, we're getting some derivatives of fentanyl, which can be extremely potent. And one of the things we've seen at some of the local hospitals here is basically a concern that with this extreme potency of these derivatives of fentanyl, that it actually is using so much naloxone that they may develop, may not have enough naloxone at the hospital for other overdoses, or even for that overdose. And Eddie, the thing is, naltrexone can be used for alcohol treatment. The idea here is that the opioid receptors may be involved in the reward system, and naltrexone is used to block that. So one of the things I do want you to know, and that's why I've got it in red, is the opioid receptors. We have three major opioid receptors. We have the mu receptor, we have the kappa receptor, we have the delta receptor. There's actually another receptor that people have thrown out there too. But most of the therapeutic components that we see are the analgesic properties of the opioids are primarily mediated by the mu receptor, okay? Naloxone blocks the mu receptor, but most of the pain relieving components, there's some data that suggests some of these other receptors may contribute to some degree, or may contribute to the other actions. But as far as the analgesic effects, is most people, I think, agree that the analgesic properties are primarily mediated by the mu receptors. So that seems to be the most important receptor with regard to these actions. So all of these receptors, they're G protein mediated. They inhibit adenylyl cyclase. And if you look at them on a molecular basis, we see that they produce a hyperpolarization by increasing the postsynaptic potassium efflux. They decrease presynaptic calcium influx. That tends to block things down. They actually impede firing and inhibit the release of excitatory neurotransmitters like glutamate. So all of those contribute to it, but we're not going to drill down to those molecular levels for you guys to know. So if you look at the cartoon here, basically what we see is that when you activate the opioid receptor, that inhibits the amount of calcium coming in. And so that decreases the release of the excitatory neurotransmitters like glutamate. So if you reduce the excitatory transmitters, that will serve to have to decrease the activation, and that tends to suppress pain and the feelings of pain. We also see that when you activate the opioid receptor. So when you stimulate it, basically what happens is calcium goes out of the cell, and so this postsynaptic receptor becomes less responsive. So what we're doing is sort of depressing everything. So there's the strong agonists. We've already talked about those. And so let's talk about morphine. This is going to be our prototype drug because a lot of analgesics are going to be, narcotic analgesics are going to be compared to morphine. Okay. And by the way, one thing to be aware of, since I do legal and criminal type things, you hear a lot of times the prosecutors and some of the people in the legal system and the criminal system refer to narcotics. Well, narcotics do not, they use the term narcotics to refer to any illegal drug. And narcotics is not across any illegal drug, okay? Typically, when we're talking about narcotics, we're talking about opioids. They produce the narcosis. So as I said, the main mechanism of action of morphine is going to be through its interaction with the mu opioid receptor, okay? That causes the hyperpolarization, which sort of suppresses the neuronal firing. And as I said earlier, and this is going to be true for all of these agonists, is that it inhibits the release of glutamate. Another substance which is there is substance P, is involved in pain, and it inhibits its action. And so what it does is it basically reduces the propagation of these painful stimuli. We call them nociceptive stimuli. The analgesia, the big thing with morphine, here's one of the big reasons these drugs became so popular years ago. We didn't have any drugs that, if we needed analgesia, the most analgesic drugs that we had, we put you to sleep. So the big thing is that analgesia was able to be achieved without loss of consciousness. That was a big thing, okay? You see a lot of morphine use in the Civil War, and when they were discovering it and so forth. The point is that pain relief could occur without putting the person asleep or near to be asleep, okay? So one of the things we do see is it raises the pain threshold. That occurs at the spinal cord. And really what it's doing is it's altering the brain's perception to pain, okay? That's the analgesic. It's really altering your perception of pain. The pain does not feel as bad, okay? Euphoria at high doses, this pleasant feeling people describe as sort of floating. They have decreased anxiety, decreased distress. So we typically aren't going for euphoria at therapeutic dosages. We are trying to basically reduce the analgesia, okay? Now, when people start abusing drugs, they're going after the euphoria. They refer to them sometimes as a dream or a nod or things like that. One of the things that you will see is you guys are not going to be prescribing any opioids in any state that I know of. But one of the things we do see is that one of the drugs of choice of medical professionals are going to be narcotics because they can get to it. We also see the way that people respond to narcotics. We see people that are in pain respond differently than people who are not in pain. They can produce sedation. That's dose related. Our biggest concern is probably respiratory depression. A couple of things that happen with the respiratory depression is, one, they're CNS depressants. So by depressing the central nervous system, that's going to decrease the respiratory drive. Another thing they do is it reduces the sensitivity of the respiratory center to carbon dioxide. So as carbon dioxide builds up with narcotics, is you don't pick up that signal. These effects, the respiratory depression, can occur at therapeutic dosages. So people can't just simply say, well, I was giving a therapeutic dose and so it couldn't be respiratory depression. I have heard that argument being made. Most common cause of death with opioid overdose is respiratory depression, okay? A lot of times now I will tell you, there are some of these opioids may produce cardiotoxicity. But if somebody comes in and found unresponsive and dead, they will almost always just attribute it to respiratory depression because that's what's perceived. Now, another thing that we see that's very characteristic is pupillary constriction, and that is meiosis, okay? People do not develop a tolerance to this. So It's very characteristic of morphine use. It's mediated through the parasympathetic stimulation of the eye, but they usually don't develop. So even though they may develop a tolerance to the other things, typically they're going to still see meiosis. And you see on this slide a picture of what we refer to as a pinpoint pupil. Morphine is a cough suppressant. It will suppress cough. We don't use morphine typically as a cough suppressant. We use a weak drug, codeine. We've also used hydrocodone. I've seen more hydrocodone being used as a cough suppressant, which surprises me. Frequently, they will produce nausea and vomiting, and in many patients, we will prescribe an antiemetic along with it. It's not uncommon for somebody to get a prescription for an opioid or morphine, and they give them Zofran with it. And what that does is the morphine tends to cause a stimulation of the chemotrigger receptor zone. Another common thing with opioids is constipation. Morphine basically decreases gut motility, and they don't develop a tolerance to it. So there's two symptoms with narcotics or opioids that patients typically don't develop a tolerance to. One is meiosis, the other is the constipation. Many times what we're doing is we're basically going to have to make sure somebody's got a stool softener, and that people on chronic opioids typically are going to have some sort of effect there, that something to address the constipation. Because basically what happens is motility of the GI tract is decreased, the tone is increased. So basically it just sort of shuts it down. Typically no effect on blood pressure or heart rate at doses we use. At high doses, we can get drop in blood pressure. We can get some bradycardia. That's usually due to the CNS depressant actions. The other thing we do see common with morphine use is we're going to see histamine released from the mast cells, that people get itching, sort of break out in sort of hives, sort of turn red. Some patients, you can get some bronchoconstriction, which we have to watch out for. But a lot of times with morphine in the hospital, they will give them an antihistamine to offset this pruritus that's due to release of histamine. These other effects, these hormonal actions, don't worry too much about these. I know it's in red, but just be aware of those hormonal actions. I'm not going to ask you anything. They can affect a lot of the different hormones, but the biggest one probably is, typically we're not worried too much about this. In general, we can see some urinary retention. So that can occur sometimes. And we do see it can prolong labor. It basically will decrease the strength duration. We don't like to use a lot of these opioids for this for many reasons. One of the main reasons is we don't want to use the opioids going across to the fetus and affecting the fetus. So we try not to use narcotics during labor as much as possible. Primarily, it's used for pain. We have seen with severe diarrhea, it can be used for treatment of diarrhea because it causes constipation. Again, it could be used for cough, but typically we're going to use something like codeine, dextromethorphan. Those are the two most common, but we may see something like hydrocodone be used, which is very similar to morphine. And another thing we do see is that it is effective for acute pulmonary edema. So a lot of times people that develop some conditions, they get a lot of pulmonary edema, have difficulty breathing, and so especially if they're in congestive heart failure. So one of the things that we see is that one of the things that helps is you're having a hard time breathing, you get very anxious over it. So some people say basically they get anxious and there's a perception that they have a shortness of breath. It drops venous tone, and that decreases the cardiac output, and it can drop blood pressure a little bit. So if some people that develop myocardial ischemia and have pulmonary edema associated with it, this drug can be used sometimes. So the adverse effects, typically respiratory depression is the one we're concerned about the most because it can cause death. We can see some nausea and vomiting. Typically, we're going to give an antiemetic, as I said before. some individuals, especially people not in pain, but people that may be abusing it, there's a good chance that they may experience dysphoria, restlessness, and hyperactivity, although we do see it sometimes in pain patients. Urinary retention, constipation, urticaria, which is the itching, and the pruritus. It can elevate intracranial pressure. We have to be careful with people that may have some increase in intracranial pressure or potential for that. So typically what we see is, here's sort of a schematic, sort of sum these up. We had sedation, constipation, nausea. The urinary retention can occur. There's definitely a potential for addiction, and there can be some respiratory depression. Okay, there is what's called the opioid triad, and that is when people come in with pinpoint pupils, respiratory depression, and somnolence. That's considered the opioid triad. And somebody comes in with those symptoms, typically they're going to hit them with Narcan. All right, so let's stop here so you can take your in-class exam with 4 questions. When we come back from lunch, we'll come back at 1. We will start talking a little bit more about tolerance. We're going to continue on with opioids, and that'll be the next thing that's there. Anybody have any questions? Okay. The first thing I will do is when we get back from lunch, I will go over these questions. So we'll go over the answers there. Otherwise, if you guys will take this, and then basically I will go over these questions. You guys have a great lunch, and I will see you guys at 1 o'clock.